So when you
The first question. Say the question so everyone can hear it.
when you were doing your cranial adjustment, that sutural compression, so what was your sequence? Like what you did first and second, and I'm assuming you did.
So
It
it's
looked like
all
you were
like-
pointing to the hamular notches as well inside the mouth.
Just anterior to that, yeah. So it's
Okay.
on the palatine mode. So that
Yeah.
my office manager would come in, and so he had his his hand on the glabella. So he's doing this portion,
Okay.
and then my thumb was in the patient's mouth on the palatine bone,
Okay.
right, just anterior to the hamular notch, and then with my free hand while he's so I have the patient breathe in and breathe out, and then I'll tell my office manager, okay, go, and they lightly compress traction while I'm on that palatine bone, and I'm twisting that parietal at the same time.
Okay.
And that's,
And
That's cool.
And I'd like to follow up that question. Why?
why I do it
How
that
did you
way.
know that? How did you know to do that? What was your indicator?
So if that therapy localization shows up, if they're an SB plus and I have them therapy localized and it weakens on exhalation, then I'll treat it in exhalation and I'll do it that way. And also if I feel that the occipit's depressed on that side, that's why I'll bring it up. But if they're SB plus and they're showing up as an inhale, then I'll do it more an inhalation. Then I'll do it the kind of the traditional way in the SOT cranial book.
How did you determine the side of, like, while you were compressing the lambdoidal suture on one side while lifting the belt?
The dollar sign
Okay.
and the TL, the therapy localization.
Okay. Excellent. Dr. Blum.
Anyone else? No, I'm just kidding. Yeah.
You could probably hear me,
No,
they
no.
won't hear you in the other parts of the world.
Yeah, that looked a lot like Denton's open parietal. Similar to that. Is that where you got some of that?
He didn't want to be mentioned,
All right,
so that's why I didn't mention him. But a lot of that work is Denton's work. I don't do the full vector
Yeah,
point
and
protocol.
that-
I don't do the full. Just I don't know.
No, historically,
disclosure.
that goes back a lot to Mel Reese, who was doing the parietal adjusting like that back, God, how many years ago was
A
that?
long time. Ask the question. Though.
That was it.
That's the question.
I want to know, yeah,
No,
historically.
a lot of it's based on the vector point work, but just disclosure. It's not vector point protocol. I just took some pieces of that, but he didn't want to be in the PowerPoint, so that's why I didn't put him in there. So it wasn't out of disrespect to him or anything like that. I was more than happy to give him full credit. He just didn't want to be in it. So it's fine.
Any other questions? Wasn't there a question for Dr. Shirazi?
Stepped out.
Okay. Well, he can ask it during the next one.
Right.
So, oh,
You got the mic there?
What did you say was the average range of motion?
It depended on their facial type. So dolichocephalic, 42 millimeters and up, mesiocephalic, 48 millimeters and up, and brachycephalic, 52 millimeters and up.
Okay, thank you.
And Brendan Stack has had like 75 millimeter range of motion. It just depends. Ligament laxity even more.
and can you describe what the different what those mean? Can you define?
I did, but I'll do it again.
Do it again.
So dolichocephalic is the narrow face profile, right? That's the kind I was telling you that has a very steep temporal eminence. That's why they can't translate that well. Mesiocephalic is sort of like the round face, and they have a less steep temporal eminence, so they can open up a little bit wider naturally. And brachycephalic is the fully developed sort of face that we're always trying to do with our functional orthodontics.